Hello, my friends. This is Dr. Velma Scanterbury, and I am a little late getting on. My apologies. I am here in Delaware, and I am Dr. Velma Scanterbury, the medical director for Dialysis Patient Citizens Educational Center. I am here today to answer your questions. I apologize for being late, but have some technical difficulties getting on and being able to connect to new technology as there were changes on the Facebook. So thank you, Denise, for coming on. Hoping that Nancy will join also. So let me know. I'm the retired transplant surgeon. I'm now practicing here in Delaware as a primary care and seeing patients. A lot of my patients have had transplants and many of them are on dialysis. So if you need anything answered or any questions you may have regarding transplant or being on dialysis, please let me know. I think most people probably were not able to get on as I could not connect earlier. So let me know if you have any questions. So Denise, are you a dialysis patient or have you had a transplant? And let me know how you're doing. This is March, which is actually Kidney Month, and many places were celebrated. I have celebrated World Kidney Day. I have put a lot of emphasis on getting people educated about kidney disease. We know that unfortunately kidney disease is silent. Most people don't know that if they were not diagnosed in stage 3, so many of my patients get diagnosed with stage 3B or stage 4 before they have any understanding that their kidneys are being damaged. So it is important to get your blood work checked. And if you are someone experiencing kidney disease, whether it's from polycystic kidney disease, which could be an autosomal genetic disorder, or it could be haphazard also. You also want to make sure that your family members get checked, because oftentimes many people are not aware of their kidneys and polycystic kidneys until they are later on in life. Diabetes and hypertension being the common ones, you generally want to make your family aware so that they may be able to get diagnosed earlier, get treated if there's any possible treatment. And then there's things like autoimmune diseases. We know lupus can also cause kidney failure and lupus nephropathy, and many patients will go on to need a kidney transplant. Lupus does not necessarily affect the kidneys in all patients, so be aware of that. Some people will have some kidney damage but never get to the point where they need to be on dialysis or even have a kidney transplant. And then for many others, there are other diseases like IgA nephropathy, which is generally diagnosed with either protein in urine and then having a biopsy showing that there is IgA nephropathy. Generally post-transplant, we have seen this appear back in the kidneys, but it doesn't necessarily lead to failure of the kidney. And so patients will keep the kidney transplant pretty successfully from IgA nephropathy, even if it appears in the transplant kidney. And then there's other diseases such as the glomerulopathies, which is focal sclerosing glomerulonephritis and membranoproliferative glomerulonephritis. Both of these are significant nephropathies that lead to significant protein excretion and can often reoccur after transplant. And some patients can lose their transplanted kidney from recurrent disease, most so MPGN than FSGS, focal segmental glomerulosclerosis. So even after transplant, it becomes important to follow your urine output for protein excretion. And that's one of the tests that's done before, as well as your blood work while you're after transplant, because you want to know any kind of damage to the kidney, oftentimes whether it's rejection or whether it's a recurrent disease, or whether it's a new onset disease, as we have seen people develop focal sclerosing glomerulonephritis in a transplanted kidney and not have it as an initial diagnosis. Was it missed as an initial diagnosis, perhaps because they were diagnosed late in stage 5 and didn't have a biopsy that could confirm that disease, or whether it was totally new and became a new disease after transplant with significant proteinuria? It has to be followed. And so we want you to not only get your blood work on a regular basis. Generally, I prefer every 3 months if you've had a transplant. Some centers will say 6 months is good, but a lot of things can happen in 6 months when you're not getting your blood work. And so if there's anything going on yes, and so you want to have any kind of FSGS diagnosed early, and so that you can undergo treatment for that protein excretion that's being wasted in your kidney. So it becomes important as to transplant to know what your underlying disease is when you get to transplants. Many people may not know. High blood pressure, you will know ahead of time, and even after transplant, it becomes important to control your blood pressure, because we don't want your transplanted kidney to be affected at the same rate that your native kidneys suffer from years of hypertension. And so we want to be careful about that, especially diabetes. We see diabetic nephropathy or damage in the transplanted kidney after transplant. It may not necessarily lead to kidney failure, but we want to be able to control your diabetes. So thank you all for coming on. Again, I'm Dr. Scanterbury. I am the medical director for Dialysis Patient Citizens Educational Center, and we're just talking about, since this is Kidney Month, talking about the different diseases that can lead to kidney failure and the need for dialysis and transplantation. We want to be able to recognize that there are some, like I said before, there are some patients who do not have that diagnosis at the time of stage 5 and had not had a chance to be worked up for the underlying disease, and therefore then they come to transplant without a specific diagnosis. And so we always have our ears keen to know what the underlying diagnosis is if someone develops proteinuria after transplant. And so we do biopsies to be able to understand that. And so it's important. So the question, I feel awful after dialysis. And so one of the things with dialysis is taking out the waste products that accumulated from the last dialysis treatment to this dialysis treatment. And generally, if a couple of things will make you feel awful in a sense of having pulled all that fluid. Depends on how much fluid you gain from one dialysis to another and how much fluid is needed to be pulled off during that dialysis, because you're going to now be squeezed like a sponge. And if you gain 5 or 7 kilos and now they're taking off 7 kilos, that's in over 16 pounds of fluid. And so your body is going to feel that difference. And so you're going to feel drained. Your blood pressure may be a little bit low. You may feel lightheaded. And so keeping your volumes low in terms of what you gain will affect how you feel after dialysis. And that's why it's so important to be compliant. If your pressures are low, you're going to feel tired. You're going to feel drained because you've just gone through these changes that need to clean your body of all this stuff that has accumulated during the 2 or 3 days between treatments. So certainly for patients who are on at-home dialysis or daily dialysis, they may not have those same dramatic changes because they're doing dialysis on a regular basis, which is why it's now advocated to go to home dialysis, where you can do it 5-6 times a week as opposed to 3 times a week. So, and also for PD, it's you are able to cleanse your body of those waste products on a daily basis as opposed to waiting 2 and 3 days. So thank you very much for that question. What are the side effects of anti-rejection medicine? Well, the body is going to, anti-rejection medicines are there to keep your body from recognizing that kidney is foreign. And to do that, the medicines are designed to dampen your recognition of your policemen, of those white blood cells that run around your body and see something as foreign. We depend on those white blood cells to keep us free of infection. You get a cold, your policemen and your white blood cells, portion of your protective portion of your white blood cells is going to recognize that you have a virus in your body or a bacteria in your body, and it's going to rev itself up and take care and fight off that infection, which causes you to have some fever and chills, because now your body is attacking whatever that process is. So with transplant, we are going to block that. And as a result of that, some of those medicines will cause you to have more risk of infection. The side effects generally is that for when we give anti-rejection medicine, we want to make sure that your white count doesn't get too wiped out. So we follow your white blood cell count, make sure that you still have a decent blood count. We want to make sure that for some of the medicines, they may cause your potassium to be high. So we won't monitor your potassium after transplant based on which medications you're on. I know for cyclosporin, we had that some patients would have more hair gain, but with Prograf or tacrolimus, now we have many more complaints of hair loss, thinning of hair. So people will say, my hair is falling out after about 3 months of being on the medicine. And for most patients, it will fall out or get thinner, but it will come back after 6 months or so. So it's just your body getting used to these medications as we're tapering down the medicines as time goes on. With cyclosporin, some patients used to get gum hyperplasia, where the gums get very thick and have to go on medicines to try to reduce the size of the gums. So, but we don't have that as much with Prograf. Some of the other medicines, such as mycophenolate and mofetil or Celsep, would also cause GI upset. So some patients will have nausea, or they may get a lot of loose stools from the medication. So those are things that we watch for and ask patients to let us know what's going on. If there are any changes in how you feel, making sure that it's not a side effect. For tacrolimus, we monitor, now the levels are kept a little bit lower, but a lot of patients would have fine tremors of the hand after taking the dose in the morning. They'll have difficulty where they may not be able to pick up a cup of coffee, or they may spill because they have tremors. And as the doses decrease over time, those get better, because initially after the transplant, we're giving you a high dose to cause you to be able to build up your levels. And then once we get to a certain level, we will then back off slowly so we can maintain that. Most patients are on steroids for at least for the first day or two, sometimes for the first week, depending on the center that you get transplanted at. And those, we know steroids can cause euphoria. They can also make patients feel very hyper initially because of the high doses, and then it's tapered down. And oftentimes from the steroids, your blood sugar may be elevated. So we have to be able to monitor your blood sugar from that, making sure that they're not extremely high. And also patients with experience, as the dose is tapered down to a low dose, may experience a lot of mood changes. You may go from being happy 1 minute to crying the next day, or even on that same day, and they may be irritable. So those are things we say as caregivers, you may have to be cognizant of those things that may appear in the transplant patients. And oftentimes you want to be really taking into consideration that it's the medications, and that they're not necessarily angry at you, but they're just going through these changes as a result of the medication. One of the things I see with some patients is that they, depending on the number of years on dialysis, they get to the point where they're no longer making urine. And so their bladder is small when they get transplanted, and now they have to make urine more often. And so they find themselves going to the bathroom every half an hour, and often getting insomnia with not being able to sleep. So those are things we tell people about. What can happen if you miss dialysis treatments? But we talked about Dialysis is a way to get all these waste products and metabolites out of your body. You're not doing it on your own. You're dependent on dialysis. So what happens if you miss? Now you have exceeded or double or triple the amount of waste products in your body, which can lead to tremendous side effects because your uremia gets worse. You accumulate more fluid because you're not urinating as much or not at all. And now you miss dialysis, you gain 5 pounds, say, let's say you gain 5 kilos over the weekend, and now you miss your Monday dialysis, and now you have to go to Wednesday, and now you've gained another 5 kilos, and now you're up 10 kilos, and you multiply that by 2.2. Now you're asking your heart to deal with that 22 pounds of fluid. That's a lot. That would put patients into congestive heart failure. They can get severe uremia where their brain goes numb. You can cause your not only heart failure, you can go into cardiac arrest, pulmonary edema. All those things can happen that puts more stress on your body. So it's not just missing dialysis, it's the accumulation of all these waste products and toxins that play havoc on your body. So you do not want to do that, because the more you do that, the more stress you place on your heart. And heart disease is the #1 cause of death for patients on dialysis. So think about how can you protect your heart. That's your lifesaver, most of all, on dialysis and even after transplant. Missing dialysis, you're harming yourself. You're not doing it. You're not harming your doctor. You're not harming the people at the center. It's just you, and that deteriorates your system. So thank you for that question. And thank you, Stephanie. 2 years post in June. Thank you so much. How long will you have to take prednisone? It depends on your transplant program. If you're a first transplant and doing well, most patients will be able to be off prednisone. Some programs will have a drug-free, a prednisone-free protocol where they give it for short term and you're off of it by the time you leave the hospital. Some programs will just give it for the first 3 days and you're off. Some will taper it off quickly within the first 6 weeks to 2 months, depending on what's your status, what's your creatinine, and whether you have antibodies. If you have pre-existing antibodies, or you've had a transplant before, or you have been on prednisone before your transplant for lupus, then it may be a little difficult to get you off of that prednisone. So now we have specific DNA testing that we look to see what is your risk of rejection and how will you respond to coming off of prednisone. And oftentimes they will follow that to see whether or not it's safe to take you off of prednisone. If you have pre-existing antibodies or previous transplant, it may be a little difficult because now you've already been exposed to other foreign tissues which rev up your body and make it difficult. So, and if you've had a previous rejection episode, they will likely wait a while before they take you off of prednisone. Programs are different. Some programs, if you do well at a year, they may take you off of prednisone. But talk to your coordinator about it, because each program has their specific criteria for prednisone-free protocols. The goal is to get you off because it causes bone disease and diabetes and weight gain, and so that's the idea. If you can do without it, they'll try, but we do not want to put your kidney at a risk for rejection by avoiding that prednisone. Any last minute questions? I know I started late, so I'm going to stay a little while. Is it possible to get Dr. Roy Srivo from University of California and Vanderbilt to give people hope, as well as what's the status of pig transplant? Is this going to really happen, or is it something that's far in the future for those of us who are not going to see it right now? The thing about pig transplant, that you have to be able to get it approved for outside of a study, and most of these transplant centers now have approval for per patient by patient. Generally they have to show that this patient is in dire need and would die without this transplant based on underlying things, and so it's not covered by insurance yet. So these protocols are done only in transplant centers where it can be covered under the research method and the medications that are being used. So until it get to the point where it's approval by the systems above, and then waiting for Medicare to approve the transplant, then the average person will not be able to get a pig transplant unless they're willing to pay the hundreds of thousands of dollars out of their pocket for what it costs, because they have to get over the rejection, the expensive medications that need to be used to prevent rejection in what we call a xenotransplant. So unless you are rich, you probably and can afford, but I think you have to have dire circumstances, even for those current transplant centers, to give you a pig transplant. What are the symptoms of kidney failure? Kidney failure is a silent disease. Most people have fatigue, don't feel well, sleep all the time, but generally they may go into congestive heart failure. There may be something that you feel is not right. You end up in the emergency room, or you don't look well. And someone says you need to go to the hospital, and then you realize you're in kidney failure. There's no specific symptoms. You may have big legs, edema flowing, shortness of breath because you're accumulated fluid, and even though you're peeing, you're not getting out the metabolites, or you're not getting out enough. So blood work being seen, many people get diagnosed because now you have a creatinine that's really high. You didn't really pick up on the symptoms that, oh, I'm so tired, don't know what's going on. And then you're being told your kidneys are in stage 4 and 5. Most stage 4s may not even have any significant symptoms. And so it's important to get your blood work checked and to know or ask your doctor what stage is your kidney function, so that you're not surprised. Most people are told when they're in stage 4 that their kidneys are failing. What happened to the earlier information? So get your blood work, get your results, so that you can know what's going on with your own body, so that you're not surprised. Well, thank you. How do you feel about the new procedure with minimal or no anesthesia for kidney transplant in Chicago? Well, many moons ago, when I was training to be a fellow in transplantation, we had a surgeon who would do spinal anesthesia and just paralyze patients from the waist down who had bad hearts and couldn't tolerate general anesthesia because you didn't want to jeopardize the heart. So it is possible to do it with a numbing procedure, but generally, because you're going deep, you really want to have at least some spinal anesthesia, so that you can have a prolonged couple of hours without really injuring or causing some significant pain to the patient. I've been a patient on dialysis for 1 year. How long does it take to get on the transplant list? You should be able to get on the transplant list, and you can get on the list before you get on dialysis. You don't have to be on dialysis to get on the list. Talk to your dialysis center. Make sure you get referred, or in some centers you can refer yourself, and make sure that you are able to get that criteria that you need to get on the list, which is making sure you're healthy, making sure you have no underlying cancers, and for some people, you can go on the website of different transplant centers and contact them and have them reach out to you to find out how to get on the list, so that you do those things to be able to get on the list. Some dialysis centers, it may say you can't get on the list because your weight is too high. Different transplant centers have different criteria. If you have cancer, they may say you may have to wait a certain number of years, but that should come from the transplant center, so that you at least know what you have to do in order to make sure that you are a suitable candidate for transplant. Is there an age limit? It varies from transplant center to transplant center. And so I appreciate all of you. I was actually my eye doctor who informed me that I needed to visit a nephrologist due to progression of my eye disease. There you go. And so it becomes very important that you don't get surprised. So if you haven't had your blood work, or your family, please encourage them. This is Kidney Month. Tell everybody you know to get on board with getting the kidneys checked, getting a urine for protein in your urine, and and make sure you do that annually, because if you are caught early, there's certain medications that we can put in place to decrease, whether it's your hypertension, the diabetes that's affecting your kidney, or whether you have proteinuria, to try to do that to be able to, if possible, slow down the progress of your kidney disease. Most African Americans don't know they can get extra time because of the GFR law that can now provide, make more people aware of. And yes, so the thing about it is that we have changed the calculation of the EGFR, which is your glomerular filtration rate. Unfortunately, some of the formulas to really get your EGFR formulas have race built into it. And if you are a person of color, there's a factor that gives you a lower total overall GFR score, which is really discrimination, because diseases are not necessarily based on race. And that had been recognized. And now if you look at your blood work, for most centers, they would say EGFR black and non-black. It should not be. So we should be using a formula that does not discriminate against patients who are of color. And that is so very important. And so many patients were able to gain more time on the waiting list, because if you take a black and white patient with the same numbers, same weight across the board, the white patient would have an EGFR of 18 or 17, which puts them on the list, and the black person would have an EGFR of 21, which takes them off the transplant list. Recalculating that would allow them to now gain that time that they were not appropriately given that EGFR to get them on the list. I see so many of you are joined at the last minute. Thank you so much. Join us next time. I actually do have a patient waiting to be seen. Sorry that I started late, and I so appreciate all of you who were here today. And so Yolanda is asking Ann Hamlet to please give her a call. Thank you so much, Yolanda, Nancy, Chandra, Melissa, Marita, Lisa, and all the folks who logged on. And we will see you next time. Take care and be well.